We respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkwiden, Anishinaabeg, the Three Fires Confederacy, Ojibwe, Odawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation.
Thank you, and good evening, everyone. We will call the Board of Directors meeting for Thursday, September 7th. We'll call it to order at 5:04. And if I can ask for any declarations of conflict of interest. Okay, seeing none, we will move to approval of the previous minutes of June 22nd, 2023. It seems like a lifetime ago, but they were included in your package under tab A. Assuming everyone's had an opportunity to review them, if I can ask for a motion to approve, please. Lori, second by Michael. Any amendments? David, you have an amendment or a comment?
Yeah, the meeting was present, right? It says present via Zoom.
And it was in person, so thank you, David.
And also my name and Linda, I think we're both present and we're not listed there.
Okay, perfect, thank you. We'll make those amendments. Thank you, David. Any other comments or amendments? Okay, if I can ask for approval as amended. All in favor? Thank you, carried, thank you. And that leads us to tab B, report from the president and CEO. David, I'll turn it over to you.
Thank you, Madam Chair. I am now sharing my screen. So welcome back officially, even though you haven't left, because we had a half decent busy summer from a board perspective and some of the issues we had to deal with. So what we want to highlight tonight is kind of an update where we are, because it's always a question, especially at this time of the year, where we are with respect to influenza, COVID, and RSV. So I'm going to take the influenza piece. I'm going to hand it over to Dr. Saad for COVID, and then to Karen Riddell for RSV. So traditionally, what we look at when we deal with influenza is what happened in Australia. Is traditionally, Australia has their influenza season in our spring and summer, and what happened during that time period is reflective of what we're supposed to be expecting. So if you look at the one year, which was last year, is this tan or orange line here. It shows the season started earlier, the increase, and it was a dramatic increase, if you recall, but also it turned into a dramatic decrease. So it went up. It was in effect about twice as high, if not 70% higher than their 5-year average. But then the descent was rapid. However, the impact was rather large. So if we go to their hospitalizations, oh, sorry, I skipped over what this current year was. If you look at what happened in 2023, though, which is this year, is the red line. So it started a little bit later than last year. The incline is not as great, and the peak is somewhere about half of what it was last year, with a decline as well. So it's larger than, past years, but half as last year. So if you're comparing it to historical averages, it's still high. It's still an early year, and these are confirmed cases. The issue is hospitalizations, unfortunately. Again, started a little later than last year. These are Australia numbers again. You'll see the Australian numbers peaked. The number of hospital admissions for influenza is the tan or orange. This year, the number who was admitted was higher and lasted longer than last year. So even though the number of influenza positive cases was less. The hospitalizations were more than last year and lasted longer than last year. What does that say? Is the testing as prominent this year as last year? Really, the hospitalizations are the true data point, because they're coming into the hospital and they're being tracked, as compared to just the previous slide, which was general testing, which is dependent upon people getting tested positive in the community and elsewhere for influenza. So, the kind of the good news I gave in the first slide is replaced by not so good news in the second slide, and what we could possibly expect. So if you look at for ourselves in Canada, what happened last year, again, similar to Australia, earlier start, the dotted line is the average for the last 5 or 6 years. This dark blue line is last year's. Again, it was earlier, similar to Australia, a big peak, similar to Australia, a big decline, a quick, rapid decline as well. However, if we go again consistent with hospitalizations, it's not exactly where we want to be. So we're going to have to see how this shakes out. Our last year's influenza season, our first cases started to occur in the first week of October. So if they are to be delayed this year by 2 weeks, similar to Australia, we'd be looking for the second or third week of October to have our first cases of influenza, or quote, the official start of the season, which is still early to have it start in October. So we're going to have to see how this shakes out. Hopefully the hospitalizations are not what Australia evidenced. Hopefully they're less, but we'll have to see. So that's the highlight on influenza. I'm going to pass it over now to Dr. Saad to talk about what we're seeing with COVID and what to expect.
Thank you, David. So COVID is circulating again. It is quite literally in the air and has made a resurgence globally as well as in Canada. There are a couple of variants that are on the radar for the World Health Organization and the CDC, and also obviously Health Canada. The one that was earlier in the year is the XBB.1.5, which you'll notice had a huge prevalence earlier in the year. And that's the one that the new bivalent vaccines are supposedly going to be targeting. But what we're seeing now is a new variant that's in circulation, which I don't even think is on here yet. There was only one case that was picked up in BC a week ago, but we know it's likely circulating in a greater volume, but is supposed to continue to have, the vaccines are supposed to continue to offer protection, hopefully, against this variant, although it is too soon to tell. This new variant is going to likely supersede the others based on most estimates because of the number of mutations it has on its spike protein. But at least preliminary data so far in other countries where it's been circulating for a bit longer shows that it is not causing more hospitalizations and not resulting in more death, which is a very good thing. And most people believe it's because of the vaccines that we have already received, as well as the number of multiple infections and sometimes repeat infections that people have, that is offering long-lasting immunity despite the multiple variants. But thankfully, the vaccines that are coming out will have some effectiveness and efficacy against this new variant. This shows wastewater data for the Windsor-Essex region, and you can see the obvious spikes at the beginning of the year in 2021, another spike in that spring. Then you can see that, we're not seeing the huge spikes that we used to see, but there's clearly upticks in the beginning of the fall, there in November, again at the beginning of the year in January, and in the spring. And then it seemed to become almost dormant and quiescent, where it wasn't really being picked up. And now, as of this past week and a half or so, we're starting to see another uptick. And obviously, it's impossible to predict how high this peak is going to reach, or whether it's going to be similar to the peaks that we saw earlier in the year. But again, it's clearly on everybody's radar. I'm sure people on this board and watching have anecdotal stories of people they know who've recently become infected with COVID or have had an illness that they just, it didn't test but isolated, which is the right thing to do. But there's no question that COVID is back. It's circulating. But of course, we're monitoring for severity because that's, from our perspective, one of the most important triggers for changes in what we do at the hospital.
Thank you, Dr. Saad. I'm going to now pass it over to Karen Riddell to talk about RSV. It's in my report, but we don't have a slide on it. So Karen.
All right, thank you. Let me just pull that up. I thought it was on the deck here. Just give me one moment. Do you want to do the surgery wait list while I find that?
Sure. Why not? So what we have is, while Karen's getting the RSV, is here's a slide because it's given an update regarding our surgical wait list, and Rosemary Petrakis is on the line as well. So Rosemary, I won't hand it to you because I know you won't appreciate that, but stop me if I say anything incorrectly. So we have to remember, prior to COVID, we had close to 5,400 patients waiting for surgery as of March 19th, 2020. As of August of this year, positive note, we're down by 40%, down to 3,200. So that's very positive news overall. Even when we last reported this, in or around March of 2023, we had 4,600 patients waiting. We're down to 32, which is an improvement of 400. What we do look at too is what's called long waiters. And those are individuals who are waiting greater than their priority timeline as set by the province. And as of August 21st, there's been an 11% reduction of long waiters as compared to March of 2023. So we've had a significant improvement in the overall number of patients that are waiting for surgery, plus those who are above target has been dramatically improved as well. So we still have more work to do, but we're trending clearly in the correct direction since prior to COVID and even during COVID, and getting quote caught up with respect to the various backlogs that occurred during COVID. I don't know, Rosemary, if I missed anything.
No, I think the only thing is the strategies we put in place. The highest number of long waiter cases by service, we've been running those rooms later into the evening. We've also been operating on Saturdays and Sundays, even over the summer, and we've got some scheduled in September. And our biggest struggle for the operating room is our health human resources and its anesthesia.
Right. Thanks, Rosemary. Karen, you wanted to share something?
No, sorry, I
Oh.
just unmuted. I thought you were going on to me next, so go
I
ahead.
am. I mean, share screen.
Oh, no, I don't need to share a screen.
Oh.
It is in the report, but just so that I don't give anybody a need
I
for
get you.
travel.
Just want it verbally. Okay, go
Yeah,
ahead.
I'll just do it verbally. That's fine. So I think just to add on to David and Dr. Saad's report on the respiratory activity we're expecting to see, our normal third infection that we typically see in the fall is RSV. So this is typically an illness that we see in younger children. It's a very common cause of lower respiratory tract infection in the fall and winter. We have started experiencing cases in August, and we do expect to see a spike with the kids being back in school. So what's important with RSV is that children that are under the age of 2 years old that are at high risk for RSV disease are actually the only ones that right now are eligible under the ministry eligibility criteria for prophylactic treatment. But there is actually a new vaccine that's been approved for adults that we're expecting to see come available. So those 60 years and above. So we are hoping to have access to that. It's a Rexv through GSK. later this fall. So that'll be important as well, because we do see some serious illness in our elderly population. So that has been the first vaccine that's received approval for older adults in the country. It was recently approved as well in the States. And that's been based on some clinical trials that showed an 82% efficacy in preventing lower respiratory tract disease in older patients, and as well a 94% efficacy in preventing illness in people with underlying medical conditions. So very promising. And we're actually hoping to have some pediatric monoclonal antibody treatment available soon for our high-risk pediatric patients. So we'll make sure that those clinics are set up as soon as we have those available. And that's it.
Thanks, Karen. And when it comes to the COVID vaccine, when are we hearing, Karen, that it's going to become available to the
Yeah,
general
so we are hoping by the end of September, early October, we'll start having some availability for our high-risk groups. So typically it starts out, as people will recall from previous years, with high-risk disease patients such as cancer, renal, lung disease, as well as healthcare workers and other high-risk categories of workers, with opening to the general public later in October. We should have access to the influenza vaccine in and around the same time. And then what's important to know is when the adult RSV vaccine comes available, that has to be given 2 weeks after either of those vaccines. You can have COVID and influenza vaccines at the same time, but the RSV vaccine, when available, will need to be given 2 weeks later or 2 weeks prior.
So individuals who are interested in the RSV, influenza, or COVID should speak to their primary care practitioner and or pharmacy to obtain that. We are not going to be doing mass vaccination centers like a couple years ago. Those are widely available in pharmacies across Windsor, Essex, and primary care practitioners.
Yeah. And we too will be getting that information out as soon as the vaccines arrived and been distributed. So there'll be lots of information coming out, as is the usual practice in previous seasons. So looking forward to that arriving.
No, perfect. Last thing I want to highlight is the positive benefits of the nurse police team. These were highlighted back a couple, 3 weeks ago. And actually just got off the phone with the police chief. What's interesting is what we're doing is tracking the individuals who are being seen in the community by the MPT team. And that's the team that has a nurse and a police officer from 1 p.m. to 1 a.m. on Fridays, Saturdays, and Sundays right now. They go out into the community and make contact with individuals who either have a mental health and or addictions issue and might need some care or direction or some advice. And we have seen that it's about 40% less ED visits. So we are tracking the individuals who are actually coming in contact with out in the community. We're tracking their previous ED visits, frequency of that, as compared to their frequency of visits after we've come into contact with them. And we've seen basically a half percentage, 50% drop in their attendances to the ED after we see them. So we're able to avoid ED visits for the individuals we come in contact with in the community. So very positive. In addition, what it's doing is, as a result, that frees up more time for individuals who don't have those issues to be seen in the ED, let alone individuals who do have those issues but are high acuity level and need to be seen in the ED. That frees up the resources to see them as well. So very positive from that point of view. So we're extending this program for another few months to see how it's going. It's catching on provincially, internationally. It's been mentioned by some nurses on social media in New York State, et cetera, raving about it when they come across it on social media. So it's not only having a positive impact locally, but it's being noticed internationally, which is great. And the team's doing an amazing job and they know they're making a positive impact. They can see it, they can feel it. And the staff who are working at the hospital and these individuals work back at the hospital recognize the benefits of it. So pretty proud of the team. And again, we started at 11 to 11, and it's the team that said, you know what, we think if we change the hours 1 to 1, will make an even bigger benefit. And sure enough, they did, and it happened. So kudos to them to, saying, hey, let's work till 1 o'clock in the morning, because we think it's going to be a positive benefit. So we're seeing people at a time of the day that they need help, where they need help. We're not forcing them to say to come to this address, from 9 till 4, Monday through Friday. That's not going to work. That's not the demand. This is the demand times, the demand hours, and it's having a positive impact. So can't be prouder of the nurse and police who are participating in this. It's been a significant positive benefit for our community, which is great. So, Madam Chair, that's my report, along with Dr. Saad and Karen Riddell. Take questions.
Thank you, David. Lori?
I had 2 questions. The first question was for Dr. Saad. So Dr. Saad, there's still a lot of self-at-home COVID tests floating around. Are they able to pick up the new variants?
That's a great question, and the answer is yes, but not with the same degree of sensitivity and specificity as previous variants. Even when Omicron came around, the home test sensitivity dropped from over 90% down to about 60 or 70%. We were able to increase it somewhat because Omicron liked to replicate in the back of the throat as opposed to in the nasal passages. So we started moving to testing people to the back of the throat first, then the nose. And with the new variant, because of the increased number of mutations it has, you have to do the same thing to still get to about 60 or 70%. So in other words, if you have a positive test, you have COVID. It's the specificity is excellent. It's still over 90%. But if the home test is negative, you don't necessarily not have COVID. You could still have it.
Okay, great. Thank you. And then my other question was for Karen. So Karen, would you mind giving us what the symptoms of RSV in older adults would be?
So they're going to be very similar to symptoms of any upper respiratory or lower respiratory tract infection. Really, the way to diagnose it is with a PCR, just like it is for COVID. Or influenza, to be quite honest with you. So we did pick up some RSV cases last year in hospitalized adult patients. We had patients that had multiple organisms. They might have had COVID, influenza, and RSV. So it's very difficult to say which one you have unless you actually have a test done. So, and then unless you're in the hospital, you likely won't have a PCR.
Thank you.
Mm-hmm.
Great questions, Lori. Thank you. Cindy?
Yes, I have a question for Dr. Saad. When we're testing in the hospital for COVID, are we able to identify the variant of interest, or just that it's positive or negative for COVID?
Only if it's positive or negative. We don't do the genetic analysis. Public health usually is responsible for that. And my understanding is that now that it's been picked up in BC, a case about a week ago, they're going to start doing those genome analyses to see if it's more prevalent elsewhere. So the other thing that can be done also is you can identify the variant sometimes through wastewater data, and that's another thing that you could do, but not that's not part of the routine testing we do in hospital.
Thank you, Cindy. David, I saw your hand up briefly. Did you want to?
Dr. Saad jumped in and answered it. It's
Okay.
through the water. They're doing genome testing. So they will start identifying the variants through wastewater.
Okay. Cindy, did you have another question or? Nope. Okay, perfect. Neela?
Yes, this is a question for the nurse police team. I'm wondering, there was a mention of calls for services, and which is 300 plus numbers. Where do we get the calls? Is it from the community, or is it through 911 redirected to the police and the nurse team?
Jonathan, you want to answer the sources now that it's known?
They're coming primarily through 911 calls through CAC dispatch, and then the police dispatch will triage which ones are really good for the NPT team to go to. They'll work in tandem with first responders. So sometimes a police officer or an EMS will arrive first. They'll stabilize the scene, and then the NPT team comes and is able to take over and release that unit back. So at this point in time, it's just emergency responses. But between calls, they're also patrolling and more high need areas and encountering people that they might see on the street as they're walking through. So also proactively identifying individuals and trying to help them in real time.
Thank you, Jonathan.
Oh, sorry, Mary?
Just a quick reminder for folks at home to check the expiry dates on their COVID kits, because there are probably a lot of old expired kits floating around out there.
Agree. Thank you, Mary. Okay, I don't see any other questions. So thank you, David, Dr. Saad, and Karen. Appreciate the updates. Very informative. So thank you. So that was for information. That takes us to tab 2, tab C, Schulich report from Dr. Jacobs.
Thank you very much, Madam Chair. Very brief report. Actually, just a little bit of good news. This year, we have our largest ever medical school class here in Windsor. So we've expanded to 42 students per year from 38. And that's in part due to the ministry expansion across the province. But for Schulich as a whole, the increase is probably the largest increase we've had between the two campuses in over 20 years, 25 years. So it really is exciting news. It takes a long time for these students to graduate, finish residency, and join the workforce. So it's the long game, of course, but we are super thrilled to be able to have a part of that increase. We've also increased our numbers for postgraduate training as well. So our psychiatry program will go to 4 residents per year this year, which is a double from where we were 2 years ago. Family medicine will maintain at its numbers of 10 or 11 residents, depending on the final shakeout per year. And we've just received approval from Central to launch an internal medicine residency stream attached to London's as well. So that means that we'll have 2 positions per year starting with this year's match. So really is exciting news for growing education here at the Windsor campus. So the rest of my report is all just FYI, but that's the good news I wanted to share. Thank you.
Thank you, Dr. Jacobs. Excellent news for Windsor Essex. Any questions? Okay, seeing none, thank you. I'll move on to tab D, and that's the financial presentation. Anthony, I'll turn it over to you.
Unmute. All right, thank you. We'll just get that put up. All right, great. Moved it. First, I want to say thanks to the finance team at WRH. They're doing a fantastic job putting these presentations together to make my life a little bit easier. So thank you in advance. So we can move to that next slide. So very quickly, we received about $6.9 million increase to our base funding for 23-24. And then also we've increased our one-time funding, $113,000 related to that critical care HHR, Health Human Resources initiatives. Some pretty fantastic things coming out of our HR team and use of those funds. It's going to our mainly recruitment of nurses is the biggest thing that we're using that funding for. So very exciting. Those funds have been able to bring in a lot of extra nurses to our team. So we can move on to the next one. All right, so financial results for July 31st. So remember, Windsor Regional Hospital's year end is March 31st. So we're about a quarter of the way through the year. So currently we are looking at a deficit of $4.38 million. which is approximately 1 day of operations. The net deficit after building amortization is approximately, sorry, did I say 4.8 million, which is 5.38 worse than our budget. We'll talk about our significant variances on the next slide. All right. As everybody could have guessed, our biggest variance to date is salaries and wages. That is overtime, budgeted overtime of approximately $3 million. Medical staff fees, we've much smaller number at 32,000. Med surge supplies, that's a big one. That's $1 million. And obviously, I'll explain it right at the end here. Drugs. So this is our retail pharmacy, but it also includes the drugs associated with cancer care in Ontario and inpatient drugs. So we do have a slight deficit of $654,000 currently. And that is projected to grow throughout the year. And then other supplies and expenses at $156,000. So that breaks down about that $4+ million deficit we're currently in. Remember, things like drugs and med supplies, and medical staff fees, we do get reimbursed for a lot of those things. So when you're looking at that previous slide, seeing big variances when it comes to our expenditures, there are a lot of offsets associated with that. So going forward, I probably won't explain that in that much detail. We'll just be going over the net differences in those categories. So with that, do we have one more slide? No. All right. So that is currently my report, and I would put forward a motion to accept it.
Thank you, Anthony. Motion to accept, Paul. Seconder, David. Any questions, comments for Anthony? Okay, seeing none, all in favor? Thank you. Thank you, Anthony. That takes us to the consent agenda. That was under tab E, and you'll see that there was minutes of the June 19th, 2023 meeting, the August 21st meeting, and also the operating results of 4 months ended July 31st, 2023. So if I can ask for a motion to accept the report. Ian, thank you. A seconder, Genevieve. Any comments, questions? Okay, all in favor? Thank you very much, everyone. And correspondence and printed materials were in tab F, and they are for your information. And is there any other questions, comments, or motions from any board members? Okay, seeing none. Our next meeting will be Thursday, October 5th, 2023. And I unfortunately believe that that will be on Zoom. So I will see everybody online in October. And with that, can I have a motion to adjourn, please? Thank you. Chris and Michael, all in favor? Thank you. I'll give everybody 5 minutes, and we can join the, since there's no scrum this evening, we can join the in-camera link in 5. We'll see everybody then. Thank you. Good night, everyone.